Hi, this is Dr. Bernstein with our February 2021 teleseminar. It just occurred to me that this is sort of an anniversary for me because I've been taking insulin for 75 years. I actually developed diabetes at the end of 1945, but I didn't know about it until I started taking insulin in 1946. So that makes it 75 years. So we can say hip hip hooray that I've survived. But the reason I've survived is given in my book Diabetes Solution, and is also given with all the lessons that I've been teaching on Diabetes University. We have a few articles that have come up in the past months that I want to talk about. The first one has to do with LDL and reiterates pretty much what I've been saying for many years about measuring total LDL cholesterol as a risk factor for heart disease. This is a study that was in the British Medical Journal, December 8th, 2020, and it was a large study, 180,000 people in Denmark. In English, I think we call them Danes. There are Lesser Danes, Intermediate Danes, and Great Danes. And they looked at baseline LDL cholesterol and then followed them for, I believe, about 9 years to see how many died. And what they found was that total LDL has a U-shaped association with all-cause mortality. In other words, high levels and low levels both affect mortality. The lowest mortality was at an LDL of 140, and you may recall that many of the authorities have been recommending, or I should say people who write the guidelines, have been recommending targets of 70, yet a target of 70 has greater mortality, according to this study, than a target of 140. The authors concluded pretty much what I concluded, that you probably should not use total LDL as a guideline. And as I suggested, there are other guidelines like inflammatory markers and possibly small dense LDL, etc. Now there's another article came out just recently in response. I'm really suggesting that it's in response to questions that have repeatedly been asked of me, namely, can childhood trauma be a trigger for type 1 diabetes? And in the past, I've given examples of situations that I knew about where childhood trauma immediately preceded diabetes, and I proposed that these patients were probably on the verge of developing diabetes anyway. But here's an actual article: the relationship between adverse childhood experiences and diabetes in Central Michigan adults. Now, this was not a large-scale study, but nevertheless it was interesting. They studied 89 people with diabetes, and I think a larger number without diabetes. and they evaluated the number of serious traumatic episodes, which they define in the article. They could be physical trauma or emotional trauma. And they found that they gave a score called an ACE score, ACE. And for the diabetics, the score was 3.275. And for the non-diabetics, it was 0.96. Interestingly, in between the two was obese children. Children who became obese subsequently had 2.9 episodes of severe traumatic events. So here someone actually studied a question that many of you have been asking me for years. And it's a small sample, but it certainly seems to indicate that kids who develop diabetes have a much higher incidence of major trauma during childhood. Someone asked a question this month that was important enough that I consider it as a special subject. The question was, does injected lidocaine affect blood sugar? And the question was probably precipitated by the fact that many dentists inject lidocaine to people who are going to have their fillings drilled or their cavities drilled out. And they do this for many children. When I was a kid, I never had any anesthetic and I didn't need it. Now, it could be that some kids really do need it, and if so, okay. But what I found on the internet is that lidocaine can keep blood sugar lowered for as long as 9 hours. So think about that if your kid is going to get lidocaine shots before a dental procedure. Next thing I'd like to discuss is the latest issue of Consumer Reports, which is a popular magazine in the USA. It may be published in other countries. The editors or the medical advisors of Consumer Reports have for years been recommending high carbohydrate foods and calling them healthy. And the February 2021 issue of Consumer Reports was particularly disturbing because they quoted a type 1 diabetic patient. And she says, I had to decide, this is because of the COVID epidemic and the effect on people's income. This young lady, I think, said, I had to decide between buying insulin, paying the bills, and buying food. And then they say she ultimately turned to a local food pantry where she could pick up canned beans, and other than string beans or green beans, they're all high in carbohydrate, vegetables, cereal, which is pure carbohydrate, grains, pure carbohydrate, dairy, which can be variable depending upon what you buy, and other items. So the pantry had a section for people with diabetes that offers fresh vegetables and fruits, just what she needs, fruits. And then on the page across from this article, they illustrate 10 snack foods that they recommend. It wasn't just for diabetics, but it was for everyone. and they recommend chocolate bars, granola bars, fruit, dried fruits, etc. One of them of particular interest was fruit-flavored yogurt, where there's not only fruit in the yogurt, which raises blood sugar dramatically, but they admit to 14 grams of added sugar. Now, 1 gram will raise my blood sugar by 10. And of course, a little kid might get it raised by 40. And here they are recommending all of these high carbohydrate foods. And it's really part of the game that's causing the high incidence of obesity and diabetes. And one wonders who, if anyone, is getting paid off for this kind of thing, because it certainly is not helpful for humans. Okay, now we have our questions, but before we answer the questions, I want to remind you that the answers I give are generic answers meant to educate the entire audience of many tens of thousands of people, and they may not solve the particular problem of the individual who asked the question. I cannot get a full history or physical exam on a questioner, and my answer might be pertinent to someone else and not to the person who asked the question, simply because of my lack of knowledge. I've heard that your physical exam is quite extensive. Do you ever find diabetic complications in newly diagnosed diabetics? Indeed, I do. In fact, I've found complications in 100% of the newly diagnosed diabetics that have come into my office. We usually average around 8 complications for newly diagnosed if they're type 1s, and 15 or more if they're type 2s. That's probably because the type 2s have been walking around with elevated blood sugars for many years and not known it. We see double vision, intrinsic minus feet, that's feet with hammer toes. We see dry skin on the feet that need lubricating. We see erectile dysfunction. We see carpal tunnel syndrome. I have an 8-page physical exam form that lists the different tests that I do for diabetes. We see Munkeberg's atherosclerosis, which I test for with something called an oscillometer, and it's quite a list. The most common is probably the double vision. And people don't know they have double vision until you put them in a dark room with a red glass over one eye and no glass over the other eye, and then you shine a pinpoint light at them, and if they have double vision, they'll see a red light and a white light. And you move it around to different fields of view, and you'll see how many directions of gaze they have the double vision in. And it reverses if you catch it early and normalize blood sugars. I'm a type 2 diabetic trying to lose weight. I find myself constantly hungry. I know the right things to eat, but the hunger is overwhelming. What can I do? Well, I can make a few. This is a tough question. It affects many, many people, and we can't always beat it. Um, First of all, don't undereat protein. Eat enough so that you feel comfortable after a meal and not hungry. There are some treatments that may help carbohydrate craving, but the first step is to get totally off the rapid-acting carbohydrates, the things that you may crave, and just getting off them may do the trick. Many people have asked me, well, can I have a piece of cake once in a while? Or I like to have half a chocolate bar before I go to bed. Well, this just reiterates the craving. Like any substance that causes craving, smoking, for example, if you've been off smoking for 2 years and you smoke one cigarette, you're lost. The same thing applies to sweet carbohydrate foods. You stay off them for a few months and you make one exception and you're lost. And I've seen this over and over. There are some treatments that may help, like EMDR, which is used to treat post-traumatic stress disorder. There are centers around the country that are using transcranial magnetic stimulation for overeating conditions, and some of them seem to be having some success, but there's nothing widespread. The GLP-1 agonists like Victoza and Byetta can curb appetite if used properly, and we tell you in my book Diabetes Solution how to use them. But when you use these oral medications, you sometimes become tolerant of them after a few months and you get hungry again. My endocrinologist snuck a lipid panel into my lab orders. He says my cholesterol is high, but I took the test right after lunch. Should I retake the test instead, unfasted? As I've said over and over, we shouldn't look at total cholesterol. It's not a marker of heart disease. And the one test that is affected adversely by eating is triglycerides. The more carbohydrate you eat at a meal, the higher the triglycerides will be an hour or two later, maybe 3. So redoing the test, whether you eat or not, does not affect total cholesterol, to my knowledge. But what should he be looking at? C-reactive protein, oxidized LDL, LP(a), apolipoprotein B, LDL particle size, fibrinogen, triglyceride, HDL. And of course, like so many endocrinologists, he's looking at the wrong thing. Do you look at the triglyceride HDL ratio for your patients? Why is this an important ratio? Well, supposedly HDL should be high. It's beneficial if it's high, and LDL should be low. But you just heard that LDL is not a good marker because its predictability is a U-shaped curve. So this ratio really doesn't have any significance. And you can tell that to your endocrinologist. Type 1 for 30 years. I'm turning 50. Is there value in getting a coronary artery calcium score performed? Well, it's questionable. It's something that you may want to decide yourself. If it sort of predicts the hazard of an abnormal test an abnormal stress test when you perform strenuous exercise. So you might want to do this instead of an exercise stress test, but I'm not recommending that. You might want to get an exercise stress test first, or you might want to do it just to see what your coronary arteries look like. It's really a very personalized decision. I recommend it far ahead of the fictitious predictors that many doctors are using today, like total cholesterol and total LDL. Why do type 1 diabetics usually require a basal insulin? Because non-diabetics make basal insulin. And if you're a full type 1 and make no insulin, you're going to need basal insulin just like non-diabetics need basal insulin. I use the freestyle meter per your suggestion. I test the meter both in healthy non-diabetics and at my labs using multiple finger sticks. I have noticed that the meter is accurate if the blood sugar is between around 75 to 95, but when the meter reads higher, say 120, it is lower than the lab by about 10 milligrams per deciliter or more. Is this your experience? It's my experience that blood sugar meters respond to blood sugar with an S-shaped curve. The S is sort of flat at the top, has a long linear part in the middle, and then gets flat at the bottom, which means that at the top and the bottom, a big change in blood sugar will not show much of an effect on the meter. I don't find that my meter reads consistently lower at high blood sugars, rather that it reads consistently off, inaccurate. And this applies to all blood sugar meters. I seek a meter that's accurate in the normal range. And the range I'm shooting for most of my patients, is around 83 milligrams per deciliter. For little kids, we go for lower blood sugars. And when you get above 100, 105, you start running initially small errors, plus or minus. Maybe you'll be 5 off. When I use my meter and I get an 83, if I have blood drawn at the lab at the same time, I get the same result. So you want to be normal, you want to be accurate in the normal range. And you know that as you get to higher or very low blood sugars, you're going to be off. And there's nothing you can do about that. But you have to what I do is if for example, I once had a blood sugar of 110. I'm sorry, I'm now getting confused with my continuous glucose monitor. My continuous glucose monitor could be way off, especially when it's high. So I once had 110 and it read 160. That was on a CGM, not on the blood sugar meter. I'm a parent of a type 1 diabetic diagnosed 2 years ago. The recommendations given us are not working, and I worry about the long-term consequences. We're considering switching to your approach and see others having so much success, but we just do not understand why the mainstream is so vehemently against this. Are there any downsides at all? The downsides are lawsuits for the physician if a kid gets hypoglycemia and dies. There's the old story that existed when I was a kid and still exists. Today, it may be more hypothetical. In my early years, it was a reality, and that expression was dead in bed. Kid goes to bed, maybe with a high blood sugar, does not wake up in the morning and is dead from hypoglycemia. The physicians are still worried about that, and the story that the big shots have given to me repeatedly, it's not like one person at the top of the pyramid thinks this way. It's that the guys who write the guidelines probably all think this way. The complications of diabetes are inevitable because we cannot normalize blood sugar. We know from the DCCT trial that to avoid the complications, you need normal blood sugars. But that's impossible. We don't know how to do that. So we keep blood sugars as high as possible to get as far away from hypoglycemia as possible. Now, it's interesting that there have been several studies, and I believe it was also in the Accord study, that the higher the blood sugars, the higher the hemoglobin A1C, the more common the severe hypoglycemia. And that probably is because the patients with the high A1Cs may have physicians that don't know what they're doing, don't know how to keep blood sugars level. So the main downside is the lawsuits to the doctors. Potential, the fear of lawsuits. Now, if you're going to shoot for normal blood sugars, you have to be very careful, very attentive, just like I am. You have to take this seriously and realize that normal blood sugars are very close to blood sugars that are too low. So if you're a type 1 diabetic, you need a continuous glucose monitor to warn you, one with an alarm, not the ones without an alarm. You need an alarm to warn you if your blood sugar is too low, and it may be inaccurately too low on the CGM, but you then check it to double check the CGM. And it takes a lot of work, but it is possible to keep blood sugars pretty close to normal and to avoid the long-term complications. And the fiction that many doctors try to perpetuate, that it's just a matter of chances. Some people are lucky and some people aren't. The guys who are careful, like me, last a long time. I am struggling with my weight for years and have had some success with low carb, but now my weight is plateaued. Should my strategy be to eat protein foods with lower fat content? My guess would be to eat less food altogether, and if you're taking insulin, lower the insulin to comply with the lower food that you're eating. Also, to exercise strenuously. And I recently got introduced to these exercise TV games where you have a mat in front of your television set, and you do activities anywhere from dancing to playing tennis, playing ping pong, etc. That might be something that you can benefit from. I've heard many people say that you recommended using regular insulin for your patients. Why can't I just use Humalog? Isn't regular an old, ineffective insulin? Regular is human insulin. Is human insulin ineffective? That's the insulin that humans make to keep their blood sugars normal, to give energy to their cells, to stay alive. Saying that it's ineffective is something you get from people who are trying to sell new patentable insulins that are only being put on the market because they're different from regular and therefore may be patentable. So don't succumb to the fiction that some new artificial insulins are better than regular. Now, there are specific reasons why regular is superior to some of these insulins. For one thing, it's slower acting than the Humalog, which this person mentions, and therefore is more likely to cover a high protein, low carbohydrate meal. And low carbohydrate is essential if you want to have normal blood sugars and not wildly swinging blood sugars. So by virtue of the fact that it's slower and longer acting, another advantage is that its potency is about right for an adult human. You can make adjustments with an insulin syringe of a half unit, a quarter of a unit, and they're probably adequate. With Humalog, which is twice as strong as regular, it's hard to fine-tune the dose. And for kids, this becomes really impossible. So we have to use, and we may, by the way, use diluted insulin for kids. And I even have type 2 adults who take diluted regular insulin. I've used Levemir insulin, that's a longer acting insulin, for many years, but need to split it 3 times daily. Is there a chance that if I switch to Tresiba, I can do only 1 injection per day? What is the best strategy for achieving 1 shot a day Tresiba? Well, it all depends if you're a type 1 diabetic or type 2. I have a number of type 2s who get away with 1 shot of Tresiba per day. They take it in the morning, and at bedtime they don't need it. Probably because it's given their beta cells enough of a rest that they're able to make their own insulin overnight. Overnight, their blood sugars don't go up even though they're not taking it. For type 1 diabetics, you do need Tresiba twice a day, in my experience. They advertise it as a once-a-day shot, but the clinical trials that justified that claim were when they gave excessively large doses that forced the people to eat all day long to cover the dose. Does dietary protein increase the secretion of glucagon from the alpha cells? Well, you could read about this in my book. It's a long story, and it has to do with something called the incretin effect. But yes, eating protein causes glucagon production, and protein can raise blood sugar, but not as rapidly or as nearly as much as carbohydrate does. What's the biggest risk factor for cardiovascular problems? High blood sugar levels or high insulin levels? Absolutely high blood sugar levels. But we have a situation with the ADA and other producers of guidelines recommending high carbohydrate and high doses of insulin to cover the high carbohydrate. And there, the high doses of insulin cause unpredictable blood sugars. And these unpredictable blood sugars cause the complications of diabetes. So indirectly, the high insulin that you need for high carbohydrate can be as harmful as high blood sugars. I'm curious to hear more about your life as a diabetic when you were first diagnosed. What was school like for you, etc.? Now, let's see. I wrote a note to myself, and I don't remember what the note meant. Yes. I think it's to remind me that my parents would not allow me to go to MIT. I had applied to MIT, and because I was diabetic, my parents didn't want me to go out of town, and I think they were absolutely right. But then at that time I didn't. And there was, I lived in New York City, and Columbia College was probably the best college in New York City, and I wanted to go to Columbia College. Now, there were 4 of us in my class. The 4 smart guys all wanted to go to Columbia College. And we would sit there in class in the back, quietly writing letters to the president of Columbia University, who was Dwight D. Eisenhower, who had been in charge of the U.S. Armed Forces in Europe during the Second World War. And we were writing letters to Eisenhower. We were pretending we were our mothers. Here are our mothers writing letters to Eisenhower. And we would start off, "Dear Eisen, how are you?" And we each had these funny letters. Well, I did not know it, but I was only 16 years old when I had to start college. And I had already gotten turned down by the admissions director at Columbia because I was under the age limit. And I didn't know it, and I didn't find out until I got married, when my mother finally told me that she had seen Eisenhower in a parade in Central Park, and she liked his smile. And one night, she got up and sat on the toilet because it was the only nearest chair, and hand wrote a letter to Eisenhower pleading with him to get me into Columbia College. And indeed, he had his adjutant turn the letter over to the dean of the college, and I ended up the youngest person in my class. I was the youngest kid in Columbia College, and I was the oldest guy in my class in medical school. So I guess she wrote, Dear Eisen, how are you? So that's the story of my childhood. My husband is a type 2 diabetic and just had a stroke. He is only 37. What concrete things can I do to make a change in our lives so he can be healthy again, or is it too late? Well, it's too late to prevent the stroke, but I would think that if he had, first of all, if he got a stroke at age 37 at such a young age, it must have been because of high blood sugars. And certainly normalizing the blood sugars can make a big difference. So I would certainly recommend that. And you could look at my book, Diabetes Solution, and find out how to do it. I'm a type 2 diabetic and have used low carb to lose a lot of weight and get off all my meds. My A1C has dropped to 5.7%, which is still sort of high. It's an average blood sugar of about 128 from 12.5%. Well, 12.5% is pretty astronomical. My guess is that it's over 300. Has my diabetes reversed? Well, your diabetes, I'm sure, has not reversed, because if you were to go back to the high carbohydrate foods you were eating before, you'd probably go back up to 12.5%. So I would suggest that you stay on your low-carb diet, that you continue exercising, that you don't gain the weight back, and assume that your diabetes has not gone away. Now, since you lost a lot of weight, what I said earlier may be incorrect. It may be that your diabetes has gotten much, much milder, which is great, but I wouldn't pretend that it's gone away. So I think you should take this whole thing very seriously, even though you've been very successful. I sometimes get cramps in my legs. Is this a sign that I should be supplementing with magnesium and or potassium? Well, in the general population of adults in the USA, the average adult, I'd say over the age of 30, gets nocturnal leg cramps, I think, twice a month. So it's not that this is a very unusual thing. If you get it more frequently than this, you can check your red blood cell magnesium level rather than supplementing with something without knowing your blood level. Check your red blood cell magnesium level, not your serum magnesium level. And if it's low, you can supplement with a soluble magnesium supplement. Dehydration can also cause leg cramps. So if you're not drinking at least 1.5 quarts of fluid a day, you might be dehydrated. There is one medication that's benign that can prevent leg cramps. I'm not saying it's guaranteed, but it can, and that's Benadryl. take one Benadryl tablet at bedtime. That's all I could think about offhand. You could look on Wikipedia or on MayoClinic.org to see what they search for nocturnal leg cramps and see what these various sources suggest. I'm a type 1. My endocrinologist is fine with my low-carb diet. Very surprising. But I am now pregnant, and my OBGYN is insisting that I need 120 grams of carbohydrate for the baby. I told her that if I eat that much carb, my blood sugars will be crazy, but she said there is no risk if A1C is under 6.5%. Is that right? I'm not an authority on pregnancy. I've treated several pregnant patients over the years, but we've always gotten their A1C under 5, and we've been successful. I've had one patient who insisted on using an obstetrician who required a high carbohydrate diet and higher A1Cs, and I pulled off the case. I told her, I don't know how to normalize your blood sugars on a high carbohydrate diet, and I cannot be responsible for what happens to your fetus or to your offspring. And the results were disastrous. She's spending her life taking care of a very sick child. I have a teen type 1 daughter who strictly follows a keto diet. Now, right off the bat, I worry about that because, contrary to what some strange people praise me for doing, I'm not recommending a keto diet. I'm recommending a high protein diet, low carbohydrate, and to produce ketones, constant ketones in your urine, which is what so many of these keto addicts are trying to do. You have to either be losing weight, burning fat, or you have to be starving the person. And I don't go for the starvation game. If someone's overweight, I do advocate losing weight. And yes, when they burn fat, they will show ketones in their urine. I don't advocate measuring serum ketones. But anyway, let's see what this person asks. She has excellent blood sugars. 90-day CGM is 95 milligram per deciliter, but that's an average. I don't know what the swings are. The problem is that in the last year, she is gaining a lot of weight. I'm struggling to understand why this is happening. What could be the problem? Well, she could be eating too much, or she could be not getting enough exercise. It could be that she has PCOS. So, and if she's not overeating and is gaining weight, I frequently say PCOS patients can gain weight from swallowing air. It's amazing. And this is a serious problem. You can be tested for this. I think you can look at the ratio of DHEA sulfate to testosterone. There are a variety of tests can be done. There are medications for PCOS, that's polycystic ovarian syndrome. You can also do a transvaginal ultrasound of the ovaries. You can try the medications that are advocated for this to see if it makes a difference. It's usually diagnosed clinically based upon symptoms rather than any absolutely certain blood test, but usually testosterone levels are elevated. Can you talk a little in detail about intramuscular shots? I know we're supposed to give them in the deltoid area. What insulin should we be using? We use regular insulin for bolus. Should we use regular for correction also? Or should I have a script for Novolog for these corrections? It all depends on several things. Many of my type 1s who are using intramuscular corrections and who want to use Humalog, which is faster than regular, and of course for a correction you want to be as rapid as possible. But Humalog is so potent that you may not be able to make a small correction. So I have many patients who are using diluted Humalog for intramuscular corrections. I use intramuscular regular for my own corrections, and I find that when it's given intramuscular, the bulk of the correction occurs in about 2 hours. So I'm happy with that, but if I wanted to ask my compounding chemist to make me up some diluted Humalog, I could give that a try. As far as Novolog goes, it's not as rapid as Humalog. It's not as strong as Humalog, so it might need less of a dilution. And it's all trial and error. There are these newer, supposedly ultra-rapid insulins, and I have, I believe, 1 or 2 of my patients using the ultra-rapid insulin intramuscularly, but these are big people who are a little overweight, and they can still get away with these newer rapid-acting insulins. The trouble with the rapid-acting insulins that have agents in them that dilate your blood vessels so that the insulin gets in more easily. The pores in the blood vessels open up and the insulin can get in there, insulin granules get in more easily. The trouble is if you dilute the insulin, you're also diluting the substance that makes the insulin act more rapidly. So the newer ultra-rapid insulins can't be diluted. I've printed out a dozen or so studies that you have referenced that show damage from high blood sugars to the brain, to the heart, etc. I also have a transcript of a talk you gave about complications where you discussed the reversal of some complications with normal blood sugars. My endo referred to these collections of studies as cherry-picked, and that there is a luck component to diabetic complications. Is this true? Well, according to the ADA, and at least according to the JDF, which is now the JDRF, when I was active in the JDF, Juvenile Diabetes Foundation, the parents wanted to believe that there was nothing they could do for the child except pay for a cure. I'm sure these were affluent parents, they didn't want to put in, most of them did not want to put in the time learning how to normalize blood sugars. They saw me walking around with my blood sugar, big 3-pound blood sugar meter, and they didn't want their kid to become a professional diabetic, so they would espouse the myth that it was only a matter of luck. And here I've lasted 75 plus years with type 1 diabetes, but I put in a lot of effort. So your endo is really saying that he doesn't know how to treat diabetes, how to normalize blood sugars, and as far as his patients are concerned, it's a matter of luck. Well, it's not. It's a matter of bad luck, because you know what's going to happen to his other patients who are walking around with the high blood sugars. It's guaranteed. What is an appropriate amount of carbohydrates for a type 1 infant 2 years old? Well, you really have to consult with your pediatrician over what vegetables he should be eating, and they should be low carbohydrate vegetables. There may be some baby foods available that don't have flour added to them and don't have sugar added to them. You have to hunt very carefully. If you can't find ready-made baby foods that are low in sugar, you can take vegetables, put them in a blender and really blend them fine, and find out from the pediatrician how much of each vegetable you should be giving the baby. But you have to intervene. You know, if he says the baby has to have a substantial amount of carrots, and you know that carrots are high in carbohydrate, you got to find another vegetable. But it really is up to the pediatrician to decide what vegetables, what vitamins, not how much carbohydrate. Because infants, like adults, don't need carbohydrate for development of the brain or for the development of anything, because they can make all the glucose they need from protein. It's called gluconeogenesis. It provides me with a great deal of motivation to see you still as active, healthy, and productive. What are your sources of inspiration and motivations? Okay. My source of inspiration for myself is survival. I wanted to live. And I was afraid of the consequences of high blood sugars. My source of inspiration for helping other patients is obligation. I feel that if you know something that other people don't know, or if other people are being taught, being given misinformation, you have an obligation to pass on what you know. That's it. So it's survival and obligation. And I might add that practicing medicine is not my favorite enterprise. I would much rather be an opera singer or a physicist. I've heard you say that it is very important for the parents to also go low carb if their child is type 1. I'm 100% in, but my husband refuses. We've answered this question before. So, but I did paste something onto this. If eating high carbo is more important than his child's health, there's a bigger problem in the household. Well, maybe we should reiterate that response. Well, I'll be looking for you again on March 31st, 2021. Thanks for watching and listening. We'll see you soon.